Yeah. Hello, good afternoon to everyone. Welcome to the session on transformative approaches to add value to healthcare provision, both to those who follow us from abroad and those here in the room in rainy Barcelona, which is not very common. My name is Maria Reventos, and I work at Corporació Sanitària Parc Taulí, which is provider including university hospital, mental services, social health services, and primary healthcare. So I'm therefore very delighted to chair this session, where we'll be enjoying a very broad set of experiences on how to contribute to healthcare sustainability by adding value through initiatives coming from the provider. The session will include 13 presentations, so we're going to be very caught on time. I ask the presenters to adjust to the 5 minutes you've been granted. Sorry? Can you hear me? Oh, okay. We have experiences from different countries in Europe, the Middle East, and the United States. And we are going to have a very broad set of topics, including risk-sharing schemes, accreditation, partnership among providers and with the private sector, and organizational proposals and projects for improving health outcomes and adapting to patients' needs. Given the vast number of interesting presentations and the shortage of time, I will not extend any longer. Just a quick reminder on the time, 5 minutes each, and then the questions will be held at the end of the 13 presentations. For those connecting remotely, you can pose your questions through the questions and answer tab on the right-hand side of your screen. And those here in the room, you can do it through the application or by raising your hands. And with no further delays, let me introduce our first presenter, Dr. Karsten Engel, Chief Executive Officer at International Society for Quality in Healthcare, who will be talking about accreditation in 2030.
Thank you. Accreditation is widely and successfully used around the world today for quality assurance and to promote continuous quality improvement, but it will need to transform itself to remain relevant in 2030. The world is changing, presenting us with new challenges. We have experienced COVID-19, the climate crisis is lurking around the corner, if not upon us already, and we have no idea what might come up next. Accreditation cannot assume that the world is stationary or that coming crises are predictable. Emerging technologies will not just be new ways of doing the same, but will have a profound impact on the care delivery model. Accreditation must not add to cost, but must help to improve cost effectiveness. New models of care are emerging with focus on involvement of patients and families as active partners, and with focus on the care pathway rather than care episodes. The traditional model of accreditation of individual provider organizations will not reflect the delivery models actually in use in 2030. Global demographic shifts towards an aging population will stress healthcare further, both on the demand and supply side. New ways of thinking have developed. Healthcare is a complex system. This means that it cannot be entirely standardized. Prudent standardization of components can, however, reduce but not eliminate complexity. A well-performing complex system must be resilient, able to adapt to both expected and unexpected conditions. Being resilient can be described with 4 words: anticipate, monitor, respond, learn. Accreditation must be able to facilitate the translation of these ideas into practice. The perspective is changing as well. Quality can no longer be defined as delivering what your peers expect you to deliver, but must be defined as meeting the patient's needs in accordance with priorities and preferences. This shift of perspective is completely coherent with shift from looking at care episodes to looking at the care journey. And now fast forward to Accreditation 2030. How could accreditation meet these challenges? Customized accreditation. Specific programs and challenges differ from place to place. Accreditation must thus be customized. Assessment must be from the user's perspective, not the organization's. Accreditation must be an integral part of the system's management strategy and must be seen as an ongoing process, not as a once-off event. While processes drive outcomes, focus should be on the outcomes achieved, not on compliance of processes with norms. The overall goal should be to increase the value add, decrease the workload, and enhance the relevance. How could this be achieved? We need to move from accreditation 1.0 towards accreditation 2.0. I say towards 2.0 because the idea is not to replace everything that has worked well until now with something else, but to use a spectrum of approaches for different purposes. Standards should not just be a compilation of criteria that characterize a well-performing organization, but should set an agenda to achieve a defined aim. In addition to specific requirements for certain structures and processes, standards should also provide guidance for the design of structures and processes, allowing for different approaches and guidance for leading complex systems. Examination of processes for compliance with requirements will be played down, while processes will instead be examined to understand why outcomes are as they are. Judgment will be based less on process compliance and more on outcomes, and reporting will focus on mechanisms rather than on a mere tick-box style compliance. Instead of telling you what you should do, standards and the entire accreditation process will help you achieve what you want to achieve. The classical survey methodology will continue to be used, but more data sources, including quantitative data from a broad range of sources, will contribute to the assessment. Thank you for your attention.
Congratulations for your presentations, for sticking to time. Our next presenter is Dr. Oliver Kroijnen, Chief Executive Officer of International Network of Health Promoting Hospitals and Health Services, who will be speaking about the new standards for health promoting hospitals and health services, optimizing health gain and building sustainable societies.
Thank you very much, and I can follow neatly on the previous talk. So I'm going to talk about the new standards for health promoting hospitals and health services, optimizing health gain and building sustainable societies. So the work that we're presenting is the International Network of Health Promoting Hospitals and Health Services. We have 600 members all over the world in about 33 different countries. And the standards are one of the key tools or the key platform that we provide to our members to engage in the implementation of health promotion and to support quality improvement through assessment. The work we have conducted builds on a previous standard set. I had the privilege to lead the process about 15 years ago with the World Health Organization to develop the first set of standards for health promotion in hospitals. That was based on a review of existing standard set from established accreditation agencies. Don't need to name them, but we looked at all the major accreditation standards and found a gap in the sense that they didn't address sufficiently the areas that we feel are particularly important in terms of workplace health promotion, patient-centered care, and continuity and cooperation. All these that were actually just mentioned as a way forward. So we have looked at that 15 years ago with our standard set. Obviously 15 years is a long time, and within our network we had various working groups and task forces that took these standards and applied them to different target groups, like children and adolescents. We had specific targets on health literacy. We had standards on migrants. And a few years ago, in our General Assembly, a proposal was made to integrate those standards from the different target groups into an overarching standards set. And that was proposed based on the work by Dr. Antonio Chirenza, who did a first mapping of our standards available from the different working groups. So the aim was to build a broader set of umbrella standards and operationalize a vision to improve health gain and ensure sustainable development within the international hospital and health service network. We invited the network expert panel, including all our network coordinators in 33 different countries, experts very familiar with quality, standard development, and others, to build a new set of standards in a 2-round Delphi study with quantitative and qualitative assessment and working groups to reflect and synthesize the input that we gathered from this global initiative. As a result, we have proposed a new set of standards at the beginning of the year, and there are 5 standards that look at the organizational commitment for health promotion, that look at ensuring access to the service, and access not just in terms of physical barriers, that is something typically addressed by accreditation standards, but also barriers in terms of communication and other cultural boundaries or barriers that exist, enhancing people-centered care and user involvement, creating a healthy workplace, and finally promoting health in the wider society, which covers both the provider collaboration along the patient care pathway, but also the broader issues of sustainable development and climate change. We are very pleased that these standards have already been translated in various languages. In terms of the languages available, I'm missing here Swedish, because we have already translated into Swedish as well with our network in Sweden, and various translations in progress, which you can see here on the right-hand side, Spanish and I think Catalan as well. We are very pleased that in some networks there's actually a link between our standards and established national accreditation agencies. Particularly in Catalonia, we were made aware that the Catalan accreditation agency has actually adopted some of our health promotion standards into their accreditation standard set, which means that all Catalan hospitals will now be subject to some extent to assessment against these standards. The work that we have finalized actually today, and which will be presented at the end of next week at our General Assembly, is to produce a new assessment form or self-assessment tool, where we have for each of the standard a set of measurable elements and rating scales, commentary boxes, which should really allow our members to take the standard set and conduct a self-assessment in their organization. It includes instructions about how to conduct a self-assessment, how to set up the team, basically everything you would do prior to a formal accreditation assessment. We're also looking to seek collaboration with accreditation agencies based on this outcome to explore ways to include some or all of our standards into existing accreditation agency standard set, because we feel that still we have addressed a major gap in what established agencies are doing, and a gap that is very important if you think about staff work like health promotion or climate change, which we have addressed. In fact, one of our members from the working group has attended the COP conference and presented some of our work there on the standard for health promoting hospitals and health services. That's all from me. Happy to be here and to be available for questions afterwards. Thank you very much.
Thank you very much, Dr. Greine. And with no delay, we'll go to our next speaker, which is Daniel Piro, Executive Vice President of Vincient's International Ventures, who will be addressing the topic Pandemic Drives Healthcare Provider and Industry Partnership.
Thank you. Well, good afternoon. Nice to be here. My name is Dan Piro, and I'm from the United States in a company called Vizient. And the title of my presentation, Pandemic Drives Partnership, is really, I think, a similar story that I probably have heard 20 times here at the conference, around where there were silos and fragmentation in the system. Unfortunately, a catastrophic event, the pandemic, forced us to really kind of rethink how we do business, and hopefully that doesn't go to waste, all of the pain and suffering that has occurred. I think it's our obligation to build a better healthcare system because of it. So let me tell you a little bit about the company that I work for. Who is Vizient? Vizient is actually a owned by hospitals in the United States, owned by a lot of the large hospitals in the United States, like the Mayo Clinic, Cleveland Clinic, Johns Hopkins, those sorts of organizations, there's a board of directors. They are my boss, and we form a kind of a support service that's specialized in a number of different areas to help this network of hospitals. It is a large network, Vizient. Some of the things we do, perhaps you saw my colleague David Levine present a fair amount of data in the last couple of days around something that we call the clinical database. It's a transparent database on quality and outcomes for about 800 hospitals. We do a lot of collaboratives on things that the hospitals want to work on. But maybe in the point that I want to talk about a little bit today, we are the sourcing arm, supply chain, if you will, for these hospitals. And we procure about $100 billion worth of supplies and pharma for these hospitals, and about another $65 billion in terms of purchase services like elevator contracts and those sorts of things. So I guess I'm unaware of anybody on the planet that procures as much stuff as we do, and in particular I'm going to talk about some of the issues with PPE and all the problems that created for our hospitals. So as you might expect, not a surprise, it's easy for us in the United States to be self-absorbed with ourselves. Please forgive us for that. It's always good to come to a conference like this, but we're a very large country, maybe twice the size in terms of miles of the European Union. We have big cities, New York, Los Angeles, Chicago. People know about that. Where I live, it's a very rural area. I'm very interested in a speaker a couple days ago talked about Kazakhstan. I live in a very similar area, very agricultural. So we have big cities, we have lots of space. But when the pandemic came in, we'll call it March of 2020, first case, Seattle, Washington, where Microsoft, Amazon, Starbucks, those kind of companies that you're aware of, within a matter of weeks, it was across the country, 4,000 miles into New York City, went from 0 to 100 miles an hour, almost unbelievably. And so some of the things that Vizient is responsible for had some problems. Quickly found there was no national stockpile of PPE in the United States. I think we all believe that. The United States was involved in a trade war with China. Didn't make it any easier at that point. Found out we really didn't have a diversified supply chain. We were dependent, just like everyone else, with one source. And really it became a situation where it was every man for himself. At least that was the behavior in the first few months of the pandemic, where some of our hospitals were actually trying to fly planes to China to bring back PPE. In addition to that, the things that we heard in this conference, staff shortage. In the United States, when the economy is good, nurses leave the profession. And the economy was good in 2019, and we were already razor thin. And when this happened and people began to be sick, it became a real problem for us in terms of it's up to us to try to mix and match and the supply and demand of nurses. And then finally, some of you who may know the healthcare system in the United States, it's sort of a strange system where it is really based upon private payers. Private payers pay the bulk of the profits that hospitals have. There is federal programs, but elective surgeries, when they drop, the revenues of a hospital drop to the bottom. So all of these things happening at the same time, pretty chaotic situation. So it was rough, first 4 or 5 months. What did we do as Vizient? Well, we had to get things under control. So some of the things that we did, we began to work with our members in terms of capacity, invested in some North American production of PPE. We expanded what we'll call a standardized program, a protocol around supplies, because everybody was mixing and matching supplies. We insisted that a very standard supply protocol. U.S. government asked our leadership to come in and help and to try to make some sense of this in terms of the supply chain. Opened up communication with suppliers in pharma where we had been transactional for the most part in the past. It allowed a much better dialogue. And one of the most important things I think for us, because we have many collaboratives between hospitals, ways to communicate, we use those on a daily basis, getting hospitals together, who had supplies, how can you reuse PPE, because we couldn't find it. Quite frankly, we had to essentially make it go farther. So that communication was incredibly helpful for us. And then finally, I think our leadership really has wrapped its head around this issue of what is a resilient supply chain. It's easy to say, that's a tough thing to do. It is going to absolutely require that we work with suppliers and they share information with us about what their production is. That's not something historically they've wanted to do, but with the sort of spend that Vizient has, we are going to insist, if you want to work with American hospitals in these categories, you're going to cooperate so this sort of thing doesn't happen to us again. So to wrap up, the lessons learned, if you're a leader, then it's going to be your fault. You've got to, and we did admit, we have some things to learn. We can't do things the same way. I think most importantly, I think all of you know, when care is needed at the bedside, guys in suits like me, we have got to do whatever is necessary to help our caregivers provide care. Supply resiliency, easy to say, but it is going to be a balance between cost, performance, and risk. We've had hospitals that say, we're going to start to manufacture gloves in the basement. That doesn't make a lot of sense to me necessarily. There's a high cost with that. It's our belief there's enough supply globally, but you got to know where it's at. You can't concentrate it in one area, and that's going to mean that we're going to have to think about distribution of where this stuff is manufactured.
Mr.
And then
Pio,
finally,
we should be closing.
Okay,
Because we're 3
done.
minutes over time.
We're done.
No,
We're done.
just finished. But
Optional buy-in not allowed. Everybody's got to participate, or
I'm
this
sorry,
won't work.
but the time is very tight, and you were.
All right. Thank you.
Still on initiatives for addressing the pandemic, but for a very different, from a very different point of view. We have here Dr. May Gubash, who will be explaining to us the establishment of a clinic for women and child health services in Dubai Health Authority. Welcome, Mr. Gubash, who is a specialist registrar of family medicine at Maternal and Child Fellowship in Dubai Health Authority.
Thank you. Hello, everyone. I would like to welcome you all to this short session, but inshallah we make it very useful and brief. Today I'm going to discuss about the establishment of the clean clinics, which was a clinic that was established during the COVID pandemic in Dubai Health Authority. We will share our experience with you, and I hope you all benefit from it. So throughout this session, we're going to talk about briefly about the pandemic and its impact, the background and the aim, the steps we took, what is the clean clinic, what are the steps we took to initiate it, and what is the general outcome. So as we all know, the WHO announced the COVID-19 as a pandemic on the March 11th last year, 2020. And due to the COVID-19, usually a lot of services were affected. Most of the most affected services are the ones who are for the vulnerable groups. So the ones that we focused on, which is the maternal and child health. These groups were neglected, especially regarding the vaccination and the care for the pregnant women. So in view of this, as we mentioned earlier, on January 29th, the first case of COVID was officially announced in the UAE and reported, and then due to the COVID-19 pandemic, the show-up rate for these services went down effectively and efficiently. So due to the due to this circumstances, we came up with the idea on April 2020 with the decision to establish the concept of clean clinic. Just let me define the clean clinic and its aim. So the clean clinic is it aims to provide a full spectrum of clinical services in a hygienic and completely safe environment at the time that has a low or relatively low incidence of COVID-19. And also to provide an exclusive maternal child health service, serve main role in providing critical service, assisting local communities to meet the unique needs of maternal child health population. And as a definition, what do we mean by a clean clinic? It's a clinic that in-houses most of the patients are who are excluding the patients who are having any symptoms of flu symptoms, fever, who has been in contact with COVID patients, who has been diagnosed to have COVID-19, just to reassure the whole environment for the patient and to encourage them to come to the clinic and take the service. So initially the target of this clinic was mainly providing services for children and pregnant women, and as they are considered a vulnerable group. The steps taken is that from the beginning we reallocated, we actually assigned a clinic that is exclusive for these services and reallocated the services from this clinic to the other adjacent health centers to give this service for the rest of the community. But our clinic was only exclusive for both, as I mentioned, child health and maternal services. During this process, we have been continuously reassessing the clinic, coming up with standards and policies with the updates of the COVID-19 and its guidelines. The clinic was established on the 5th of April. We have general standards, of course, for the clinic. The clinic has, whoever came to the clinic has to be wearing the mask, of course, maintain a safe distance. And also what made it special is at the door, the triaging door, we had doctors and nurses who are triaging patients in. We were allowing only one escort per child as a parent to attend with his or her child. And we did not allow any escort with the pregnant ladies, only for some exceptions, of course, but just to maintain the safe distance, decrease the contact among patients, and decrease, of course, consequently, the rate of infection. So some of the triaging questions were basically asking the patient whether they had the symptoms, any kind of symptoms, including fever, flu-like symptoms, were they in contact with the COVID-19 patient, were they diagnosed to have any COVID-19 symptoms, as well as did they have any travel history. If so, they were redirected to another health center to be assessed fully and see and reschedule their appointment accordingly, depending on the symptom or if they were proved to have the infection or not. So, as I mentioned, we were offering exclusively the child health services and the maternal services. From the child health services, we are giving the vaccination services, newborn screening, bilirubin screening, developmental screening, and also hearing tests. Regarding the maternal services, we followed up with the pregnant lady from the beginning, from booking until even some very late stages of gestation. Some of them were following up until 40 weeks. And before even reaching the hospital, we were following them up fully. Assessing the high risk were referred directly to the hospital, but most of the patients, they were feeling safe to follow up with us in the clinic due to these standards established. And consequently, we were very blessed that the percentage of attendance increased significantly from April to July. You can see from here you can see that from the chart, the number of patients has increased significantly from April until July. About 75% in the child health service, and from the maternal service, it was even the rate was even higher, 215%, in which the patients whom attended started at 800 patients until 1,800 patients approximately. So in conclusion, this was a very useful, let's say, experience that we had. The experience that we would like to share with that it contributed to a very high significance in assuring the attendance of these patients and this vulnerable group. And consequently, the concept of this clean clinic was also established in other health centers in which in service of other vulnerable age groups, including the immune compromised, the people who weren't able to come to the hospital. Most of the vulnerable groups were given another chance to, or another health centers are reallocated as a clean clinic due to the success of the first clinic established for child and maternal health. It is always useful to work as a multidisciplinary team and learn from the experience of the pandemic. I'm very grateful to be part of this Congress, and I'm very happy to hear your experiences as well. Thank you so much for your attendance.
Thank you, Dr. Kubash. We now welcome Carmen Carmona, the Infrastructure and General Service Manager at Altaya, a hospital here in Catalonia, who will present, again, a practical solution out of COVID pandemic on how surgical operating safety during COVID multipurpose operating room. I please ask you, the presenters, to stick to time. You have the clock down there.
Thank you. Okay. Okay. Hello, I am Carmen Carmona, and I am the head of Infrastructures and Facility Service for Altaya. Today we want to explain how we developed the new concept of a multi-purpose operating room for patients COVID and no COVID. We are a non-profit trust located just north of Barcelona. We provide care for around 300,000 people, and we have about 2,000 professionals and an annual budget of approximately 200 million euros. In the pandemic context, we had a drop of 88% of our normal operation capacity. That had a terrible consequence for all patients. And in addition, there was a financial impact. So we needed to find a fast solution. And the way was to accelerate the decision process with a multidisciplinary group. Normally, this sort of change could take months, but in this case, we condensed it into a few weeks. This means that we could identify the key challenge and develop solutions to return capacity to close to pre-pandemic levels. In Catalan, we use AAA, APAR, asepsis, and agility. Obviously, is an excellent mark, but in English, APAR refers to isolation, and agility to resume as close to normal operation capacity, and asepsis to stop the sepsis guarantees being broken, all with the aim of protecting both staff and patients from biological contamination. The first task was locate an operation room. I think this is not my present. I think I have a...
You have what? We have a problem because the presentation has not been updated to the newer version. Yeah. You have to overcome this challenge too. Yeah.
It's no matter. The first task was to locate an operation room that allowed us to isolate it from the surrounding areas. When we found it, in this case operation room 10, we isolate the areas close to the operating room by automatic locking doors. Well, we guarantee the asepsis by maintaining, we guarantee the asepsis by maintaining the overpressure of the operating room in all conditions. The airflow of the surrounding corridor is managed by a variable air pressure system. And this means it could regain agility, allowing us to treat COVID patients in 50 minutes. But more importantly, we could decontaminate the space in 2 hours for non-COVID patients. The system was controlled by interactive screens at the entrance, making it very easy to do as well as secure. These actions mean Joe. These actions mean that we were able to return to near normal operation capacity, recovering about 50 operations a week, as well as maintaining full asepsis guarantee for all patients and maintaining our staff safety. This action also limited the financial impact to the hospital gave us a rapid return on our investment. What we learned from this project was the success of a multidisciplinary teams. By reducing the time of our decision-making, it led to faster and better outcomes for our patients. This also led us to develop a cost-efficient and a practical solution for isolating areas, whether they are in our centers or other hospitals. We were very pleased to be recognized by the International Hospital Federation in the program Beyond of Call of Duty for COVID-19. And we would like to thank the organizers for including us today, and thank you for your time.
Thank you very much, Carmen, not just for sticking to time, but for overcoming the challenges the organization placed on you. So thank you very much. Now we're going to let aside the pandemic, and we introduce Professor Joan Pradas, Senior Researcher at the Catalan Cancer Strategy of the Department of Health of Catalonia. He will be talking about centralization policy for complex cancer treatment in Catalonia, with the title, Easy to Audit and Edit. Thank you very much, Professor.
Okay, thank you very much. Good afternoon. Okay, here we are. So I will deal with one of the hottest cancer policy topics, at least in Europe, Australia, Canada, and United States, which is the centralization of cancer diseases. And particularly, we formulate the question, is this kind of reform, the centralization of diseases, easy to audit and edit? Well, the beginning of this story is quite similar in different countries and regions. At some point in time, that was 2012, we realized that the quality of care that cancer patients receive is totally different in accordance with the center that they were treated. You can see in the figure the probability of relapse after rectal cancer surgery. So these differences, the differences between the green line and the Catalan line, the blue line, is dramatic, and it shows huge differences that we couldn't tolerate as a health authority. So basically, we had the problem of horizontal inequity, patients with similar needs with receiving different care, and of course, with potentially worse outcomes. So what we do, we apply the centralization policy. Everyone has a different model, but we are not Finland. We had 64 public-funded hospitals participating in cancer care in Finland. They just centralized everything, everything what sounds complex in the 5 main teaching hospitals. So we had to adjust our centralization policy to our system. So on one side, we developed hard policy tools, like we set up a law in 2012, indicating those authorized centers that were allowed to treat these specific cancer diseases. This is one side. The second was the use of conditional cash transfers. If you, non-authorized center, continue to treat this kind of diseases, you will get no reimbursement for this activity. And the third point is a map indicating the flows between the non-authorized and the authorized centers, following a geographical sense. The second aspect is that we have to assume that we were dealing with a crossroads between politics and science. So in a way, we had to legitimate in front of our providers why to centralize in one place and not to centralize in another. And in that sense, it was so useful, so important, so relevant, the use of population-based clinical audits. I cannot extend any comment on that, but it's so relevant. So here what you can see is on the left column is that what we centralize sometimes is curative intent surgeries for pancreatic cancer, rectal cancer, stomach cancer, and so on, with the respective case thresholds, the number of annual surgeries that the centers have to have in order to be able to provide this kind of treatment. And sometimes what we centralized was the whole care pathway. So for pediatric cancer patients, for sarcoma patients, or for head and neck cancer patients, we centralized the full diagnosis and the full range of treatments. So just as a matter of, as example, we had 50 hospitals treating stomach cancer before the regulation, and today we just have only only 18. And before the federal regulation, we had 30 hospitals treating sarcoma in Catalonia, sometimes just one case or 2 cases annually, and today we just have 3 centers. So I will like just, yeah, my time has ended.
Yeah, your timer is not working.
Okay.
I think we're trying to challenge all the speakers now. So
Okay.
Just go ahead, I'll tell you.
Okay, so just to stress two last points. When we analyze the unintended and indirect effects of the centralization in the health systems, we realized 2 things. Even if we focused on malignant tumors, non-authorized small hospitals were referring patients with hidatidosis, which is a non-oncological disease, or patients with thyroid cancer, that this is a cancer that you can typically treat quite well in many hospitals. So in a way, there is a risk of duality of the healthcare system. And the second and final point is that we analyze the quality of the interorganizational relationships between the non-authorized and authorized centers. And the experiences are so different. We found multicentric tumor boards in a positive sense, but we also find a lot of duplication of tests, a lot of discoordination and uncertainty about who has to manage an acute complication. Thank you very much.
Thank you, Professor. I think you stick to time, even if you didn't have the timer. Please, for next speaker, which will be Dr. Marc Potter. He's the head of research and innovation of the Fondation Santé Service in France, and he will be sharing his experience on how to tailor services to patients' needs through the quality of life measurement as a tool to improve hospital practices. Just please set up the timer for him. Thank you very much.
Oh. No. So, hello everybody. What we talk now, oh sorry for this. You are now talking about quality of life and hospital at home. So we're in organization based in, I don't know. Yeah, okay.
You have to point the screen
yeah,
over
okay.
there. Yeah.
So we're an organization of hospital at home based in Paris, and we treat every day around 2,000 patients. Hospital at home is growing rapidly in many countries, and obviously it's better to be at home. And there is a high satisfaction from the patient as measured by the satisfaction questionnaire. However, there are a few data published on the quality of life in hospital at home, and we wanted to do a study on this to collect data in order to improve what we can do so for the quality of our care. For this, we used a well-known questionnaire, which is EQ5D questionnaire, which has an advantage to be a very simple questionnaire with 5 questions on mobility, self-care, usual activities, pain, and anxiety, depression. And on top of this, there is interestingly a visual analogic scale from 0 to 100, where the patient's state is his perception of his health status. So in 2 weeks, we collected not far from 500 questionnaire, and we had a broad range of patients in age or in type of disease. Here you have the results on the 5 dimensions. So you can see that 60% of the patients had difficulties in mobility, 63% in their usual activities. A large part of our patients had pain, suffer from pain, and less in the deterioration in self-care, mainly elderly patients, neurologic patients, and patients in end of life. Surprisingly, only half of the patients express difficulties like anxiety, depression, which is a bit surprising according to the severity of the disease we treat. Here you have the results of the visual analogic scale depending on the type of care we provided. And as expected, nursing, neurologic rehabilitation, palliative care had more deterioration than other diseases, such as post-surgery, obstetrics, or even chemotherapy. A couple of focus. Here is, interestingly, a demonstration of the discrepancy of perception of the health status between the patient and the nurse. In blue, you have the perception of the patient measured by the visual analogic scale. And in yellow, you have a more objective measure, which is the Karnofsky index, which is measured by the nurses. And you can see that for the vast majority of the patients in this population in palliative care, they are overestimating their health status, which can explain some of the difficulties we have to talk with the patient. And it's the same situation for the group of amputated patients. Another interesting finding was that we could measure the action of some of the healthcare professionals. For example, here again in palliative care, you can see on the left that when there is a palliative care team in place, there is much less anxiety, depression than when there is no team. And we have the same trend with GPs. When the GP goes at home to visit the patient, there is much less anxiety, depression. So what can we do with this? Obviously, this study gave us many opportunities to improve quality of life. We reinforce our mobile palliative care teams. We encourage GP to visit patients at home. At the opposite, we have seen that the chemotherapy, there is not a lot of burden with patients with chemotherapy, so we decided to limit the print of hospital at home, for example, in reducing the logistic burden. Pain is always a challenge. I think it's a challenge for everybody. It's the same for us. We use PCA, we use laughing gas, we try to develop non-drug alternative, but we still have to work a lot on pain. And social support is very important in hospital at home. I would say that 50% of the problem in hospital at home are medical and 50% of the problems are social. So we need to have a strong team of social workers to work on this and to offer services on top of the medical care. So should we go even further? You have seen that 63% of patients are no longer doing their usual activities. So we try also to develop accompaniment by volunteers. We develop an experience of art therapy at home. We are developing also socio-aesthetic for patients that have a problem with their body image. So all these things can be done on top of the traditional care. So conclusion, globally, patients are very satisfied to be treated at home. They are satisfied by the care provided, as we can see in the satisfaction surveys, but this does not mean that the quality of life is good. So we need to measure quality of life if we want to improve our practices and the range of services we want to offer to the patient and the family. Thank you very much for your attention.
Thank you very much, Dr. Peter. Now, changing the scope, we will be listening to Dr. Marta Rubiera, stroke neurologist at Hospital Universitario Vall d'Hebron, who will be sharing her experience on applying value-based healthcare on her field with a presentation Beyond Measuring, Cultural Changes Toward Measuring Patient Outcomes and Continuous Improvement on the Stroke Care Pathway. Thank you very much, Dr. Rubiera.
Yes. Good afternoon. Here you can see the usual pathway a patient with a stroke experience, and he passes through a lot of health services without a real connection in between. So we wanted to change this to a more patient-centered healthcare, sharing common guidelines and, of course, sharing outcomes, trying to establish what is the really outcome that matters to patients. For that, we established our value-based stroke care in the Hospital Vall d'Hebron. And the first of all, we did some multidisciplinary workshops with families and patients, trying to establish exactly what were the outcomes that really matters to the patients. And we selected a set of scales that allow us to capture these outcomes that matters to patients, the PROMs. And actually, these scales were in concordance with the ICOM organization. We decided to measure clinician-reported outcomes that we obtain through the structured electronic medical record in the hospital. And we also wanted to recollect PROMs, and for that we established telephone or email surveys at different time points along the follow-up, and obtain a database of both CROMs and PROMs with aggregated data that allow us analysis of our procedure, but also provides a patient report that can be shared with the health carriers of the patient, and can be consulted by a stroke neurologist when they did the follow-up of the patient. And here are our preliminary results. For all acute stroke patients admitted to our stroke unit, we included 1,300 patients discharged to home or to a social rehabilitation center. And the first thing we saw is that there is a dramatic decrease in the rate of PROMS fulfillment along the follow-up. Only 25% of patients at 1 year filled our surveys. We also saw that, as expected, there is a high proportion of stroke patients with very poor PROMS, and there is no improvement of these PROMS along the follow-up in the majority of patients. And finally, we wanted to study to identify independent predictors of 3 months poor PROMS. And as you can see in the table, the most potent predictors of poor PROMS at 3 months were actually the PROMS recollected at 7 days. And this is important because it allows us to detect early the patients that can have the stronger problems. And to conclude, it is feasible to establish a value-based healthcare program for acute stroke patients, but it requires a multidisciplinary approach and a complex organization for recollection of outcomes. In our case, we detected a dramatic decrease in the PROMS compliance along the follow-up, a lack of improvement of these PROMS in the patients, but we were able to identify some early predictors of poor PROMS. And with this, we are doing some improving actions that is a more earlier and intensive control of our patients when they go home. And we have a new tool to recollect PROMS. This is Nora, is a web platform and app for communications for patients that we have developed in our stroke unit that has increased our PROMS fulfillment at 3 months for more than 90% of patients. And we are also participating in an EIT health program, the Value Project, that aims to improve the stroke care process by data mining. And these are the images if you want to consult them. And with this, I want to thank my collaborators, because of course this is a teamwork, and none of this is possible if there is no multidisciplinary team. And I want to thank you for your attention.
Thank you very much, Dr. Rubiera, for your presentation. Next is Dr. Ana Clupés, Deputy Director at the Catalan Health Institute of Oncology, who will be talking about her vast experience implementing risk-sharing schemes with the industry with her presentation, Payment by Results Schemes for New Cancer Drugs, 10 years of experience from a comprehensive cancer center. Thank you very much.
Good afternoon. It's a pleasure for me to be here with all of you in our city, in Barcelona. Thank you for the scientific committee to choose our study in order to present here today, and that gives us the opportunity to share with you our experience. And the experience is the payment by result scheme for new cancer drugs during 10 years in a comprehensive cancer center in Catalan Institute of Oncology. All began with this question: how to bring drug innovation? Patients, clinicians, managers are involved in the same question, in the debate on the clinical benefit of new drugs, and in comparison of new drugs, of therapeutic innovations include cancer drugs, of course, must limit 3 objectives, 3 targets together. First, ensuring patient access to real effective solutions. Second, sustainability. And third, reward for innovator investment. Oh, sorry. Why payment by results? Therapeutic innovation is often associated with uncertainties that make difficult to determine its therapeutic value in clinical practice and consequently the price. Where there is this uncertainty, incentive-based schemes as risk-sharing agreement or payment by results could be alternatives for prices based on fixed price. Where the Catalan Institute of Oncology is a comprehensive cancer center, as I say, that provides the cancer care to 50%, approximately 50% of cancer patients in Catalonia, in coordination, in collaboration with 4 tertiary reference hospitals and with a network of 20 medium county hospitals. In 2010, ICO decides to begin to apply this kind of schemes, and in 2011, we signed the first scheme with a drug in lung cancer. The objective of the study is to describe the results of the implementation of this kind of schemes in our center during 10 years. Here in this slide, you can see the most important data of this experience. During the evaluation period, we signed 17 schemes with in 15 indications and with 10 pharmaceutical industries, and we included more than 2,500 patients. And this gives us and allows us to a standardized method that gives the opportunity to harmonized process in Catalonia, pharmacotherapeutic harmonized process, to introduce this kind of experience for all the country. In this slide, you can see the distribution of the patients between disease and the refound. In the 17 patient-based schemes, the refound was 5.1%, with a range between 20.6 to 1%. 59% of the schemes use health outcome based on effectiveness, and 41% use effectiveness and safety together. Most of them, 29% of them, are in non-curative setting, and of them, 53% are in first line. Based on our experience, there are 2 key elements in this to apply to implement this kind of schemes. First, the decision. Our decision is based on the activity of P&T committee, the commission, the Pharmacy and Therapeutic Commission, that decides based on uncertainty of the drug that which kind of scheme are going to apply, and the implementation of them are based on the clinical practice guidelines. And second, the second key element for us is data monitoring and evaluation of results, of outcomes, using the electronic prescribing system that we have, that is the name spoke, which integrate the decision-making algorithm based on clinical practice guidelines, and the formularies that outcomes are recorded, integrated with the prescription service. Conclusions based on innovative contribution to practice is that real-world data, we use real-world data in order to take decisions and bridging the gap between efficacy and effectiveness. Second, that patient by results could reduce uncertainties between payers and providers and achieve a value-based decisions. Intangible benefits are the alignment of stakeholders, and last but not less important, it's our experience show that the development tools related to organization, as for example, information systems, technologies, make the implementation possible. Thank you for your attendance, and here you can see my contact data. Thank you.
Thank you very much, Ana. We now introduce Mireia Martinez, a primary healthcare physician from CAP Comte Borrell, from CAPSB, a primary healthcare center here in Barcelona, who will present a collaborative project between primary healthcare and Hospital Clinic for more integrated care of breast cancer patients. She will be presenting the first results of a shared follow-up between primary care and the hospital. Thank you very much, Mireia.
Thank you. Hello, good afternoon. I'm going to explain our program.
Get closer to the microphone.
Yeah. That.
Please, the timer. Can you set the timer? Thank you very much. Mireia Martinez.
Mireia Martinez.
Can you please set up the timer? Thank you.
Yes.
Okay. Can we try to sort that out and maybe go to the next speaker and go back to Mireia, please? Mireia Martinez, the next after Mireia will be Leandro Luis. Mireia, if you don't mind, we try to look for your presentation while Leandro Luis. Then we're widening our scope even further with welcoming Dr. Leandro Luis, Hospital Manager of Central Lisbon University Hospital, who will be addressing the topic of the implementation of quality improvement program in the ambulance management in his hospital, Central Lisbon University Hospital.
Well, thank you very much. Dear ladies, dear gents, I just want to thank you for listening and to the IHF for this opportunity. I'm kind of nervous, I may say, because we had such a good presentations, and I'll just present something truly simple. It's just a transformation that I did in my ambulance transportation unit with my team that allowed us to get some better outcomes and a more engaged team. So we had a problem. We had a problem that was related with an increase of inpatient ambulance transportations. We had, in the beginning, 130 transportations per day. Then we started to get 200, 250. Well, we started to get delays, a worsening lead time response to the requisitions of the clinic units, and we had to rethink our organization. So we tried to create a quality improvement program. So this program wanted to improve our quality, the quality of our delivery of our transportation service, allowing the hospital to be more efficient, to provide a better perceived quality for our clients. We used for it an integrated value-based approach focused on our clients, creating kind of some solutions for each problem. We used kind of a problem-solving approach. We identified 10 quality factors, which each one had a factor problem. We identified the causes, and then we turned out to the solutions. You can see the factors, you can see in there. We have the hygiene and clinical safety, comfort, ambulance equipment, ambulance presentation and image, employee education behavior, presentation and image, lead response time, schedule accomplishment, communication, and client support. For each one of them, we identify the problems, what happened, and then solutions, and we apply them. We create for that responsibilities. We create some new responsibilities, new units inside our unit, our sub-units, which was hygiene, safety, and maintenance office, formation office, operation management office, and client support office. Doing this, we started to create some charts, some record sheets to implement for every clean and disinfection procedure, to start to clean and disinfection audits, and created a dedicated space with color-based zones to get a better process in this hygienization of the ambulances. Then we try to get more comfort. We try to rehabilitate our ambulance fleet, and we started to buy new ambulances to get a better quality service. If you think, most of the times patients, when we need to get them to the hospital, they need to feel safe, and for that we needed to get some equipment, some better equipment. We started to work with the Institute for Medical Emergencies. We implemented some record sheets to ensure that all equipment was always there and guaranteed safety for them. Better presentation of the image. You can see we paint our ambulances. We have acquired one ambulance specifically for extracorporeal membrane oxygenation rescue, which we do all over our country. We invested in employee education and presentation. We created a program of education for them to do better their work. We developed an happiness department, kind of an happiness unit, where they were able to get some incentives for their work. And we started to improve our response time. We improved our IT systems. We started to work with flowcharts, and then we were getting better results. We used some IT, such as GPS systems, to know and optimize all our work. I'm always finishing. We created a client support office, which allowed us to reduce most of our problems which were related with communication or lack of it. And then we had results. From one year to another, we increased our productivity. Until August this year, we had more ambulance transportation done than all the last year we had. It wasn't because of COVID. Okay, COVID increased our workflow. So we had more response, more productivity, best times, and less complaints. Thank you.
Thank you very much, Dr. Luis. We now welcome back Mireia. I remind you she was going to be talking about the first results of a shared follow-up between primary healthcare and the hospital for breast cancer patients.
Yes. Okay. What? Yeah, now. Okay, so good afternoon. I am going to share our project of breast cancer patients. Yeah, the project consists the patients with breast cancer. We offer to the breast cancer patients an alternative appointment between hospital and primary care to receive the advantages of the health promotion and the cancer knowledge in the hospital. The study is set up in the integrated health area of Barcelona Esquerra that covers a 500,000 population, and it's coordinated with the different healthcare suppliers, the care suppliers that collaborate with us, with Hospital Clínic of Barcelona, and 12 primary care centers. The inclusion time with 2016 and 2019. The aim of the program consists the aim of the program is to identify the long-term adverse events and discard disease reliefs. On primary care, we take care a lot of the review global health aspects like cardiovascular risk, bone health, asthenia, arthromyalgia, neurotoxicity, chemobrain, hot flashes, sexual dysfunction, emotional disorders, and also with pay attention in toxic habits, obesity, sedentarism, endocrine therapy compliance, and quality of life. Our results that all data was registered in an electronic platform that we created, and it's named OntoCerra. We included 2009 patients. The average age was 63, and 184 patients presented one tumor, and 20 patients 2 tumors or more. And we classify the risk of the patient in different stages, depending on the treatment and the stage of the tumor, and within low, intermediate, and high risk. Family physician detect a lot of high risk. In our patients, we see incredible numbers of osteoporosis, 77, 79 high cardiovascular risk, 86 sexual disorders, 40 hot flashes, 40 depression, 13 smokers, obesity, and sedentarism lifestyle. In physical examination that we did in every visit, we detect 6 possible cancer relapse, 6 pathological vaginal bleeding, 2 patients were referred to the gynecologist, and 1 to the oncologist department. And then we made a scale number of complementary tests during our visits. We made an 8 blood tests, 2 liver ultrasounds, 2 extra mammographies, and 72 bone densitometries. And our contribution is creating a platform that we can share easily with the hospital and the primary care, and providing the patient with a high health support. Thank you.
She's not only had challenge, but she's been quick as well, so thank you very much, Mireia. The next presenter will again focus on how to tailor health services to patients' needs, this time by analyzing how to optimize frail patient care in a hemodialysis unit. She's Dr. Marta Arias, and she's a nephrologist at Hospital Clínic in Barcelona.
Good afternoon. Today, what I will do is talk about, as you said, how to optimize frail patient care in our hemodialysis unit. And the first thing that I would like you to understand is that the chronic kidney disease is a major health problem. Oops, sorry. The previous one, here. It's a major health problem. So our patients, every year, if this CKD progress, they enter in the end stage and they need what we call hemodialysis or renal transplant. No? It's a renal replacement therapy that costs a lot of money. So our patients, when they enter in a dialysis program, they are progressively older. So for you to understand, 50 years ago, it was impossible to enter a patient over 50 years old in a dialysis program, or even a diabetic patient. Nowadays, we are entering patients over 80, over 90, over 80, including over 90 years old. That is progressively linked with fragility in our patients, and that is linking what this session is.
Marta, you should point
oh, sorry.
Yeah.
Linking to what this session is transforming the care that we have to give to our CKD patients. So that's the reason and the objective of our study. And, sorry, the objective was to evaluate the fragility of our hemodialysis patients in order to provide a better functional, nutritional, and cognitive, emotional care. And this was obviously a team, I don't know how to point, but whatever.
No,
it's okay, it's okay.
Yeah.
This was a teamwork. It was impossible just to do this by one person. So what did we do? We created a checklist. I don't know if you can see it very well here, but all the health care professionals that were involved in this dialysis patients' care had a task. Talking about nurses, what they did is they assess the frailty using the 5 criteria, and if the patient accomplished 3 criteria, what was considered as frail. Also, if the patient needed a social intervention, and if the patient had any cognitive impairment. Talking about healthcare assistants, what they did is assess the dependence and also the full risk. And the doctors, we were in charge of assessing the comorbidities. Nutritional and functional assessment were performed by nutritionists and physiotherapists. So what did we see? That using this frail test, our patients were catalogued as frail at the 25% of them. And that we were more or less, we thought we will get these results because, as I said before, they are progressively older, our patients. But what really amazed us was that 46% of the patients were catalogued as pre-frail. And these patients, almost 60% of them had high risk fall. All the patients catalogued as frail, obviously they had high risk fall, but look at the patients that are pre-frail and the no frail patients, 40% of them also had medium risk fall. The dependence was around 25% using the Bartel index. So talking about functionality, our physiotherapists used this test that is a short physical performance battery that used the patient has to do a balance test, has to walk, and has to sit and stand, and with that you get a score from 1 to 12. So the worst score that was below 8, we had almost 38% of our patients with that score. We use this color code, as you see, red, yellow, and green, to see how our patient, the results were, and our physiotherapist decided what type of exercise the patient will do to try to recover that functionality. So, but unfortunately, with the exercises that we decided to do, we were not able to improve these results. If you see in the lower results there, at the baseline, we have 32% patients with this score below 8, and we were not able to improve actually their worst the results. And it was mainly because we were performing cardiovascular exercises instead of strength exercises, because I will explain later that our physiotherapists didn't have enough hours to attend and do this type of exercise. We obtained better results with the nutritionists, again, using this color code from red to green, and with these nutritional scores, the patients that were better, that is the ones below, we were able to increase the percentage thanks to the interventional nutrition that the nutritionist did. So talking about the cognitive impairment, 14% of our patients had some cognitive impairments, and the mental health status was not very good using this EED test by the psychologist. So what do we do to improve this frailty in our hemodialysis patients? So I have to say that we have
Doctor, we
a
should
quality
be
system. Okay,
finishing.
so what we have done is improve the number of hours of our dietitian, because we are convinced that we have to intensify nutritional assessment. We have improved also the number of hours of our physiotherapists to combine strength and cardiovascular exercises. And also we have reinforced the time of the nurse at the end of the dialysis session, and we have included a psychologist in our team. Infrastructure support is also, it has been improved, and we will include volunteers to support these professionals. So just to finish, what I would say is the paradigm of quality of care for patients with CKD has changed, requiring care that adds value to this care. And management models that includes assessment of frailty in daily clinical practice and provides sufficient resources are needed, including nutritionists, physiotherapists, psychologists, and decreasing the ratio nurse patients that we are offering right now. Thank you very much.
Thank you. Thank you, Dr. Arias, and sorry to rush you, but we're really short on time, and we still have our last but not least presenter, which is a psychiatrist, expert in economic evaluation, which will be focusing on the cost effectiveness of test biomarkers pre-hospital guided TPA in patients with stroke through the Markov model. Professor Antoni Serrano is Deputy Director of Mental Health Services at Parc Sanitari Sant Joan de Déu, here near Barcelona. Thank you very much, Toni.
Thank you very much, and thank you all for staying here. We are at the last presentation. Well, I'm like to talk about pretest biomarker for administering TPA in patients with a stroke. This research was done in a very large group of people led by Joan Montaner from Vall d'Hebron Institute. And as everybody knows, stroke is the leading cause of death and disability worldwide. So treatment has to be provided at least time as possible. And there are several point-of-care biosensors that can provide a quick identification of biomarkers that differentiate the type of stroke, so we can provide the treatment in minutes. But there is still a need of an evaluation of this effectiveness and cost effectiveness of these biomarkers and point-of-care biosensors. The aim of this study was to evaluate the cost effectiveness of a blood test biomarker with pretest hospital-guided TPA compared with the standard care at the hospitals in the patients with suspected stroke, with moderate or severe stroke, in the less than 4.5 hours from the symptoms onset from the perspective of the Spanish National Health Care System. Our test was combined by two biomarkers, retinol binding protein and N-terminal natriuretic peptide, which has a sensitivity of 20% and a specificity of 100%. And we conducted also a sensitivity analysis, adding another third biomarker, which is glial fibrillary acid protein, which raises the sensitivity to the 51% and maintains the specificity of 100%. The cost of the test is around 100 euros per unit. So we'd like to test this, but not in a randomized control trial, but with a decision tree model. Well, this model was, I think this is a pointer, no. This is the model we created based on the literature review, the clinical expert's opinion, and an ongoing clinical trial. The model was tested for construct validation, verification, and cross-validation by clinical experts, and evaluated using a first Monte Carlo simulation. The acute phase consists on the patient management and outcomes from stroke onset to 90 days, which is the part from the left, and the part from the right are the models from the day 91 until the first year, and the one on the right and down, it is the one that gives us information about from the first year until 15 years of follow-up or death, which occurs first. Our outcomes were, as you can see, MRS 0 to 1 is non-disabled patients, or 2 to 3 only requiring secondary prevention strategies, MRS 4 to 5 severely disabled patients, and MR6 it was death. What we find was the administration of that test biomarkers in the ambulance could guide pre-TPA administration compared with standard care, providing patients more quality of life gained, more life of years gained, but also with a slightly greater costs. The ICER, which is the comparator between the costs and the quality gain, it's 888 euros per quality gained, which is far below the threshold. And using 3 biomarkers, the ICER was slightly a little bit better included. This is the plane that shows that most ICERs of our analysis are below the threshold, which is the red line, which goes from the top to the bottom, showing that this could be a cost-effectiveness intervention to treat patients with ischemic stroke. In this, sorry, there is no line. Oh yeah, this line. That curve represents the probability of that the use of that biomarker test could be cost-effectiveness for each willingness to pay threshold, and showing that for 24,000 euros per quality, which is the standard in health economics. That test biomarker represents a 77% probability of being cost effective. Well, this is the last one. Here I want to show you the maximum cost that could have the test in case of every levels of sensitivity of the test, because you know when you are in the ambulance, you do not always know if this stroke is an ischemic stroke or is a stroke mimics or is another kind of a stroke, so sensitivity could go down. And then we show that including the fewer sensitivity tests could have, at 10%, there is much more price allowed to be cost effective in the test. So we can say that 100 euros per cost, it could be a nice price to make this functioning. Well, I'd like to thank the Instituto de Salud Carlos III and Biomarkers for initiating on-site and faster ambulance stroke therapies, who granted this project, and also the Catalan Stroke Plan, the Spanish Neurological Society, and the Spanish Stroke Research Network, who provide data to construct our model. And Dr. Montaner has a patent on a biomarker, and Dr. Bustamante, Maria Rubio, and myself, we've got personal grants to conduct this study. These are my contact details if you need more information. Thank you very much for your attention.
Thank you very much, Tony. We overcame the main challenge, which was making the 13 presentations in 90 minutes, which was quite defying. I don't know if you have any questions. I've checked, and I don't think we have any questions online. Although we have 3 minutes because the closing ceremony is starting at 2 o'clock. So should any of you pose any questions? No? I had a question prepared, but it's a quite general question. I don't think the time will allow us to do the question. So thank you very much to all presenters. Sorry for interrupting you, but really it was a big challenge to meet the 90 minutes. Thank you very much, and see you in the closing ceremony.